So getting back, oral substitution therapy, what is OST? It is defined as administration of daily dosage of opioid medicines with long-lasting effects to patients with opioid dependence under medical supervision. Now, this definition is restricted to very small portion of addiction. So we know that the addiction is to crystal meth, addiction is to hash, cigarettes, so many other compounds. But when we talk about oral substitution therapy, it is only related to the opioid and opioid derivatives addictions. So it's not as a whole. It's a very specific group where it can be prescribed. When I was doing my training back in early 90s, in Institute of Psychiatry, Rawalpindi General Hospital, at that time WHO Collaborating Center, with Professor Malik H. Mubashir, I was unfortunately or fortunately made in charge of this OST even at that time. So back in 90s, the concept was very much there. The concept is an old one, so it's not a new concept. It's an old concept. At that time, the income tax department was providing us with opium tablets, which were made by government of Pakistan, and they were 500 milligrams of opium tablets. And we were using them as oral substitution therapy to treat the patients with opioid and opioid derivatives substance of addiction. So we used to make a plan, although that plan was not very scientific, because ideally speaking, these medications has to be given for a long period of time. But we were using them for a short period of time for 2 to 3 weeks, depending upon the dosage of the addictive substance he was taking, calculating again roughly the dosage, and then tapering it down. By the time the patient was discharged, he was off OST. So that was a crude method of overcoming the, symptoms of detoxification, symptoms of withdrawals, and it was a way of detoxifying the person for a short period of time. So supposedly a patient was coming to me with an heroin dependence, and he was consuming, say, 1.5 grams of heroin. I was putting them, again, I said that's not very scientific, but this is what we used to do at that time. So I'm just giving you my experience. So what we were using was that we were giving him, say, tablet opium, we call it tablet O, and tablet O was given half tablet in the morning, half at noon, and one at night, and then it was tapered off every third to fourth day, and gradually in 2 to 3 weeks time, it used to stop. And after that, if the patient is not having any withdrawals, he was sent back home on other supported medication for other various problems he was having. This was one of the methods which was used for oral substitution methodology. And I considered it to be very effective because our outcome was good. The patients were comfortable in the hospital on just the opium tablets. The problem was that we had to dispense the opium tablets inside the ward. There was only very few number of people who were getting it as an outpatient as well. So I still remember I had an old man who was 90 plus, maybe more than that. According to Professor Mubashir, he was more than 95, so probably 100 years of age. And he was opium dependent, and with the special circumstances, we were dispensing him the opium tablets. He was a very old man, but he used to come every week to us to get the opium tablets, and he was very careful in taking them, and he used to continue them. By any means, if he was not able to come after a week and he's late, he usually was having lots of withdrawals like lacrimation, fatigue, lethargy, difficulty in walking, all those symptoms. So the basic paradigm of oral substitution therapy is the supervision. Supervision, prescribed, and calculative dosage. So this is one of the most important feature of again this addiction. So chat box में एक comment आया, मैं उसका जवाब जरूर देना चाहूँगा. Let me check it. लिखा हुआ है, बड़ी बात है कि अफीम के नशे के बावजूद इतनी लंबी उम्र पाई. Yes, this is what I wanted to respond as well. So the type of, again, off the record, I'm talking about this, although it is recorded, but I still want to say it. Back in 70s and 80s, opium was definitely one of the addictive substance. And then it was refined and heroin was made, and then other drugs started popping up. At that time, Pakistan was a rich country because opium was produced in a neighboring country from where it came to Pakistan, and from Pakistan it was again sent to the rest of the world, and we were rich. But later on, of course, things started changing. Back in 70s, 80s probably, 80s or 70s, there was a big, again, movement by US and other countries, and all of the poppy farms were destroyed. So we were without opium, and we started getting, again, more poor and poor over the period of time. So it's a known fact that the drug money makes you rich. And now there are all chemical drugs which are coming from abroad into Pakistan, which are being used by Pakistanis and other people around the globe, like crystal meth, ephedrine. They're all tablets, and ecstasy. They are all in the form of a tablet, so they are synthetically produced. So the kind of thing Kamran mentioned, that a person with opium dependence living up to that age, yes, it's a known fact. Even the Chinese people who were considered to be a finchi in layman terms, long time back before their independence, they were dependent on the opium a lot. They had long lives. I don't know about now, but of course, they are not, again, opium dependent anymore. And addiction is a big problem now if somebody is involved into it. But with the change of culture, with the change of power, with the change of our influence on the Western world, those safe, natural, dependence-producing substances, they went away, and their place was taken by synthetic drugs, which unfortunately are designer drugs. They don't give you any problems otherwise, but they are highly addictive and produces lots and lots of problems associated with it. So answer to your question, yes, opium was a good drug, and it was definitely, again, causing lots of, again. So my mouse has stopped working, so I have to just check it out from where I should start doing it. Okay, come on, go ahead. Okay. Oops. Okay, so opium substitution therapy, again, as I mentioned briefly, and I will describe it again. Basically, it was used as a harm reduction, and it has multiple, again, tiers of service delivery. Along with, again, other therapies available, NSEP, opioid stimulation therapies, there are other therapies available, and they are used for HIV prevention, forms of second tier of harm reduction. So main theme, the word used is harm reduction. So the harm reduction means the kind of the problems that drug is causing, we have to reduce it to a level where they are acceptable. OST is substitution of the drug, user primary drug of use. Sorry, I cannot see the screen, so I have to move this. Also, I have to adjust this mouse before I move forward, because otherwise I won't be able to see the screen. Or maybe, come on, no. Okay, let's do this. Now I can probably move my, okay, screen, mouse, otherwise. Okay, so I was here. So OST is substitution of primary route of use, injectable, with non-injectable routes, which is oral. Now, oral substitution therapy reduces few things which are considered to be one of the main parameters to be involved in it. One, further existence of untreated additional diseases, risk of relapses, use of illicit drugs, spreading of HIV and hepatitis, drug trafficking and prison, healthcare cost, HIV, hepatitis, other associated issues, likelihood of committing other offenses, and risk of all causes of mortality. So this is the basic outcome of oral substitution therapy. Okay, let's move forward. Come on. No, they don't want to go forward. Okay, so basically the agonists, opium agonists, are heroin and morphine. So morphine is the prime compound, and then subsequently heroin came out of it. Its antagonists are naloxone, naltrexone, and beta phenyltretazine. Unfortunately, naloxone was available in Pakistan, but it was discontinued some time ago. And phenyltretazine is never seen. I have never experienced it, but naltrexone is another compound which was there. Opioid antagonists are usually given in three forms. So naloxone, naltrexone, and the third one usually are given in either in injectable forms or oral tablets. One of them is available as a nasal spray as well, naloxone. So it can actually help in certain ways. But if you take opioid antagonists, the withdrawal effects suddenly are very severe. So we have to be very careful about it. In acute usage, we usually don't use it. What is the actually association of the opioid agonist and antagonist? So opioid agonists basically have the analgesic action. So they basically are used for pain. So when I was doing my house job in surgery, we used to give morphine injection to people on the first post-operative days. And they were very good analgesics. So half an injection of morphine and person was without any pain. He was sleeping well. Second day, maybe a quarter of it, and the third day, none of it, and the patients were in the time of recovery. But if we continued giving it, like these days, again, synthetic narcotic analgesic injectables available are given by the family docs in hordes of amounts, and people do get addicted to it, even if it is given once in a week. So that's the tricky part. So main role of opioid agonist for therapeutic reason is pain. There are other uses as well in cancer patients, palliative cares, in again chronic illnesses, etc. But of course, their use are limited. So we have to be careful about them. Okay. Pharmacokinetic components, opioids, what do they do? So what they bind to specific receptor sites in the brain, and these are called opioid-bound receptors. They usually are, again, excreted through breathing, gaseous exchange and metabolism, and then blood flow situations, which are unfortunately sometimes problematic as well. Oops, I disappeared again. Okay, I came back again. Sorry about this juggling thing today. So basically, again, the point here is that the opioids are orally or injectably drugs. And oral substitution therapy is only for opioid and opioid related compounds. Physiological effects of opioids are to relieve and alleviate pain, but they have very severe withdrawals, which have multi-organ thing. Euphoria, and again, out of the system, out of proportion things are relatively high. People do feel elated, euphoric, but they are usually numb, quiet, sitting at one place and not involved in much of the social activities. On the other hand, the other, again, drugs, synthetic drugs, like ecstasy, people are up and above, they are roaming around in the city, they enjoy fun, talk, communicate, etc., etc. So this kind of drugs make you slow down, numb, isolated, pain-free, and euphoric. That's what it is. Now, oh, okay. One of the opioid agonist is buprenorphine. It has a very specific structure. It comes by the name of Suboxone in the Western world. Buprenorphine, and it's a combination of buprenorphine and naloxone, which is a sublingual tablet, 8 milligrams and 2 milligrams. So 8 milligrams of buprenorphine and naloxone combination is considered to be taken once or twice a day, very helpful in actually substituting the opium and opioid related derivatives. And the craving for the drugs is considered to be reduced if this combination is used rather than only one drug is used, like buprenorphine or only the naloxone. So they are available in the market. They are taken once or twice in a day. They are sublingual. They help in the withdrawals. They help in maintaining long-term effects in which the patient avoids the original opioid and opioid derivatives compounds available in the streets. And whenever we have to start buprenorphine, then we have to wait for moderate withdrawal symptoms. So initially it is not given for, again, immediately after or during the course of addiction. So first we have to make sure that the person stopped it, maybe for 48 hours or maybe more than that. So the prescribed guidelines suggest that the patient should have moderate withdrawal effects. Only then the oral substitution therapy should be initiated. It should not be initiated right away at the time when the person is still on the opioid, again, addictive substances. The second is you start with a low dose, 4 milligrams per day, and gradually you increase it up to 8 milligrams twice a day, 16 milligrams per day. Usually you have to wait for 4 hours to have its effect get into place. And up titrate and try to reassess frequently how much dosage is needed for that specific person. If he starts developing craving or something like that, then of course we have to be careful. If there are no cravings and the person is stable, we stick to that dose for a longer period of time. Buprenorphine was available in Pakistan, but the tablets which were available was 0.1 milligrams or 0.2 milligrams tablets, which was surprising because, and people were taking about 10 tablets a day, which was 2 milligrams of 0.2. So taking 10 tablets a day, every day of a buprenorphine, which was expensive because it's not available through the ministry and a controlled substance. It was usually a smuggled drug. So people were taking 10 to 20 tablets per day, which is a high dose, which is a reasonable dose. But of course, taking 20 tablets of 0.2 milligrams to make it 8 milligrams per day was tricky. I had an experience of prescribing this once or twice, but then I realized that this is not a way to move forward. Eating 20 tablets every day for a patient for a long term till the time we would be able to gradually wean him off, say in 3 months, 6 months, or a year's time, it's tricky. So again, unfortunately, not available in Pakistan. So buprenorphine self-initiation. Usually people can take it on their own as well. The step one is the diagnosis. You have to have a very clear-cut diagnosis that a person is taking opioid derivatives and not other drugs associated with it. Because if they are taking, say, crystal meth along with the opioid derivative drugs, then of course this drug won't be sufficient. So you need more. Second, like if a person is again using fentanyl, which is again opioid derivative, you have to wait for few hours, 24 to 48 hours, 3 symptoms of withdrawal, and then wait at least 12 hours and 3 symptoms of withdrawal, and then you initiate giving the buprenorphine. So self-medication, you acknowledge, you diagnose yourself, you stop taking the addictive compound, wait for 24 to 48 hours, and then start from the low dose, gradually increasing it to 16 milligrams per day. This is a scale which is set COWS, Clinical Opioid Withdrawal Scale, COWS. It's a very simple scale. It is not having any copyrights. It's an old scale, 2003. And I remember Mahnoor made a scale DAST, Drug Abuse and Screening Test Scale, which is now available in Urdu as well. So those scales are helpful in assessing actually the quantification of the addiction and the improvement over the period of time as well. So if the COWS score is, again, as I mentioned in my previous slide, here, COWS score 6 to 10 or substantial patient discomfort. So if this score is 0, 1, 2, 3, 4, and some of the scales they have 0, 1, 2, 3, 4, 5. I'm sorry, Manu, I never used DAST here. I should have used. So DAST or COWS, the scale is minimum score of 6 to 10. So if a person's heart rate is, say, 101 to 120, his score is 2. He is having tremors, 1. Then he is having irritable and anxious, 2. So 2 and 2, 4 and 1, 5. And then the third score, runny nose. So its score is 6, which makes sense. And then you say, okay, fine. Now we have the withdrawal symptoms. We can initiate the opioid agonist therapy. Buprenorphine is one of the drugs which can be used starting from 2 milligrams per day, gradually increasing it to 4 milligrams and 8 milligrams per day. If we use Suboxone, the combination of naloxone and again buprenorphine, it's a better option, less craving, less withdrawals, comfortable, and over the period of time, it can be tapered off, maybe in months, maybe in years, depending upon the level of motivation, compliance, and so many other factors you people are aware of it. So patient who presents with opioid withdrawals, overdose, or complication of withdrawals, we have to evaluate exclusion criteria for Suboxone. So the COWS score is more than 13, right? And 12 hours since short-acting opioid was used, and 18 hours since intermediate-acting opioid was used, or 48 hours since fentanyl was used, that standards start. But if the person is having COWS score of 13, 18 to 48 hours or since fentanyl or post-naloxone reversal, then of course macro dose, big dose. And if the COWS score is less than 13 and the opioid withdrawals are less intense as well, then we can start the tablets at home as well. And if the COWS score is less than 13 and there are no withdrawals, but person wants to quit and he is abstinent for some period of time, then the micro doses are needed. So mega dose, standard dose, home dose, and micro dose depends on the numbers of the COWS and the number of, again, your motivation to withdraw or quit the drugs. That is important. Some questions in the chat box, I believe. Okay, let me check them again. No, okay, there was nothing there. Now, what are the side effects of buprenorphine? Short-term side effects are numbness, insomnia, dizziness, headache, and drowsiness. And long-term side effects are anxiety, confusion, digestive problems, increase in depression, and decrease in pain tolerance. That is more complicated with opioid, again, agonists. Naltrexone versus naloxone. Now, these are opioid antagonists. So the person who recommended this topic to be covered was thinking about these things to be included as well, although this is not actually, this should not be included in opioid oral substitution therapy, but because I'm talking about Suboxone, so I want to talk about naloxone as well. Naltrexone and naloxone are two compounds which are opioid antagonists. Long-acting drug use as a part of comprehensive treatment plan, and naloxone is for short-acting drug use in response to opioid overdose. Naltrexone is used for the control of cravings for several substances, and naloxone is used only for opioids. So sometimes we give naltrexone for alcohol and other related compounds as well, and it reduces the craving of addictive substances, right? So a broader range, naltrexone, again, shorter opioid range, naloxone. That's the one of the difference between the two. They both are available in the form of tablets and the nasal sprays and the injectables as well. Injection is much easier, once in a month, and you have less craving for addictive drugs, all addictive drugs, most of them. So it reduces the craving. It has a different mechanism of action. Naltrexone and naloxone, again, various names for it. Naloxone comes by the name of Narcan, common name across the globe. And naltrexone comes by the name of Revia and Deped, commonly across globe. They both are used for opioid addicts in recovery and prevent the craving, but naloxone only for opioids and naltrexone generally other addictions, few other addictions as well. Both are available, again, in the Western world, not available in Pakistan. They were available in the past, but not now. So there was one local company who was actually promoting this. I don't know whether they do have it or not, but there is a possibility that they still are giving it. But I don't know. I haven't seen them in various pharmacies, so I don't know if they are still promoting it or not. So buprenorphine actually is, again, because it is an opioid agonist, it occupies the heroin and opioid receptors, and there are no withdrawals or the pain. That is the mechanism of action. थोड़ी सी ब्रेक। हजूम गम में भी तौहीन ज़ब्त गम ना हुई, इस एहतियात से रोए कि आंख नम ना हुई। इस एहतियात से रोना कि आंख नम ना हो is again unfortunately a complicated situation, but still it is one of it. Okay, let's move forward. Methadone, buprenorphine, naltrexone. Now, in Pakistan, some of the clinics they have opened up, they are methadone clinics. They're not buprenorphine or naltrexone clinics. They are actually methadone clinics. And it has full coverage and generates effect, methadone. So again, we'll talk in detail about methadone oral substitution therapy. But one of the complications or the contraindications for oral substitution therapy is hypersensitivity to these drugs, which is understandable. Incompatibility to provide informed consent. Of course, if the person is not giving the consent, you cannot give it to. In the West, in Pakistan, again, covered medication is still in practice and lots of people are given that. Uh, Contraindications also includes hepatic impairment, respiratory dysfunctions, severe dependence on other depressant drugs like alcohol and other stuff, renal and biliary spasm, ulcerative colitis, but they are relative contraindications. So all other physical morbidities, except for not giving the consent or against sensitivity to these drugs, all are relative contraindications. So anybody can be given it. You have to titrate the dose. You have to be careful about it. Now talking about methadone. So again, methadone is federally regulated opioid treatment program. So it's actually run by the government, right? And even in Pakistan, it is run by the government. In some of the institutions where this is now promoted, it is actually a very controlled system of dispensing methadone. It is available in the liquid or tablet form, methadone, but it is supervised daily administration is the requirement. Now, it's a very tricky situation. I will come up with this in detail more about it. And patients with multiple unsuccessful prior treatment attempts or who need daily structured support should be put on methadone. So if somebody had 3 relapses in the past, he attended 2 rehab programs, he was admitted for a longer period of time, and he is still having relapses, those are the kind of the people who are usually, again, encouraged to go on a methadone treatment plans. So if somebody wants to go for a methadone treatment plan and he was having addiction problems for 6 months time and he wants to quit, highly motivated, then probably the methadone treatment plan is not for him. But anyways, the chronicity, complexity, repeated relapses, supervision, daily, again, psychological and social intervention, those are the people who are best candidates for methadone treatments. Again, methadone is a controlled drug. It was developed in 1937 in Germany. So it's a very old drug, older than any of the antipsychotics. Less than, again, it's very economical, very cheap. It's not a very expensive drug, probably much cheaper than the opioids themselves now. So it's economical and people can afford it. And even the government can afford it because it's much less expensive than the original opioid drugs. There are more than 50,000 people in US in 2015. So it's a big number of people who are in this program and they are taking them. And they obviously use simultaneous other drugs, but it reacts with sedative drugs, benzodiazepines, alcohol, and again, barbiturates. So you cannot give methadone and benzos together. You cannot give methadone and phenobarbital together. You cannot give methadone and in some cases antipsychotics, sedating antipsychotics as well. So be careful about that. It cannot be prescribed simultaneously. Now there is a conversion table for methadone. So the methadone clinics, which are opened up in, again, Pakistan, federally regulated by the government, they calculate the dosage of opioid drugs and then how much they need the methadone, and then they prescribe the methadone. Simple formula is less than 100 milligrams of opioids, 20 to 30% of the 10 to 15% of the methadone. Again, 100 to 300 milligrams of opioids, then 10 to 20%, or again, 5 to 10% of methadone. If a high dose of opioids, 600 to 1000 milligrams, which is a mega high dose, I don't think so anybody can afford that much, then of course the daily requirement is dependent upon the situation and you have to titrate it. Onset of action is within half an hour to an hour. Peak effect in 1 to 7.5 hours. Steady effects last for 3 to 5 days. So long half-life. Duration of action with repeat dosing is usually 24 hours to 48 hours, depending upon the type of addiction. Elimination half-life is 60 hours, long half-life. So it stays in the system for a couple of days. Even if somebody misses one day, this never means that he cannot take the drug the next day. They can, and even after 2 days, they can. But again, going to the treatment facility and getting the drug is compulsion. And toxic levels are relatively achieved with a shorter period of time. So it has to be monitored every day when you are titrating the dosage. Methadone blocks the euphoric effects of the other opioids that may be taken concurrently, which provides a deterrent agonist using opioids. Methadone, the perception of pain signals without producing the telltale euphoric high that is typical of opioids. So methadone is a kind of the drug which won't make you euphoric, but it will definitely give you an agonist effect. And the dependence and addiction without euphoria is the target. And then gradually, of course, you can withdraw it depending upon the time of the situation. The side effects again includes nausea, constipation, diarrhea, weight gain, dry mouth, vision problems, and again, depending upon the doses, so you can alter or manipulate the doses. Long-term side effects of methadone. It can cause nerve damages, cardiovascular problems, liver damages, changes in menstrual cycles, reduce attention span, again, and number of other side effects. These side effects are again have to be monitored by regular blood monitoring, maybe once in a month in the beginning and once in 3 months after that. So whosoever is taking methadone should have the blood test, especially the liver function test, once in a month in the beginning and once in 3 months after that. That is the rule of the thumb. Drawbacks of oral substitution therapies. One, they have to go to the, again, locality or the place where it is dispensed every day. Eligibility criteria is very, again, stringent. 2 or 3 relapses in the past and again, intense symptoms. If you are still opioid dependent, you cannot take methadone. Again, it's a complication, the stigma of taking methadone. You're going to the hospital every day and taking the methadone. Everybody will know, okay, there is something wrong with this guy. Travel is sometimes very difficult. And there are physical side effects, of course, that I have mentioned earlier as well. लिखा किस्मत में जो तेरी तुझे मिल ही जाएगा, तेरे पास ना आया तो किधर और जाएगा, तू भी कर ले कुछ सब्र तुझे मिल ही जाएगा, ना भाग पीछे इसके वो तेरे पीछे आएगा. If we can wait for some period of time. Okay, this was it for today, oral substitution therapy. Any questions? Any
Sir, मेरा question है.
You joined, so you want to show your presence? Okay, go ahead.
नहीं सर, प्रेजेंस शो करने के लिए नहीं, वैसे ही एक सवाल है मेरा.
अच्छा, चलो पूछो.
अच्छा सर, आप वो जो बता रहे थे कि वो कॉम्बिनेशन आता है जिसमें बुप्रेनॉर्फिन भी है और नलोक्सोन भी है, और उसका एडवांटेजेस ये हैं कि लेसर विड्रॉल्स, लेकिन सर थियोरेटिकली स्पीकिंग उसके तो ज्यादा स्वेयर विड्रॉल्स नहीं आने चाहिए. वन इज अ पार्शियल एगोनिस्ट, द अदर वन इज एन एंटागोनिस्ट. तो कंबाइनिंग बोथ ऑफ देम वुड रिजल्ट इन मतलब मोर साइड इफेक्ट्स. थियोरेटिकली स्पीकिंग तो ऐसा होना चाहिए.
Mechanism of action of naloxone is different pathways than opioid agonists. So they have two different set of pathways where these two drugs affect. One is reducing the craving through dopaminergic system, and other is opioid agonist, which is affecting through the again lambda omega receptor, whatever the opioid receptors are on that. So that is the difference. And that is the reason why there are lesser side effects. So if you go through the mechanism of action of naloxone and buprenorphine, they are two different drugs. The question that you are asking is कि अगर उसको दो दवाइयां दी जा रही हैं ऐसी कि वो एक दूसरे के इफेक्ट को नलिफाई करेंगी, नहीं. वो नलिफाई नहीं करेंगी क्योंकि उनका मैकेनिज्म ऑफ एक्शन डिफरेंट है. Am I right? You got my answer, or you're still thinking of the same?
सर एक्चुअली देखिए ना, मैं ये नहीं कह रहा वो नलिफाई करेंगी, मैं तो कह रहा हूँ वो पोटेंशिएट करेंगी. जैसे वो कह रहे हैं कि हमने इमीडिएटली नहीं देनी बुप्रेनॉर्फिन क्योंकि वो पार्शियल एगोनिस्ट है, तो वो विड्रॉल्स करवा सकती है. आपने वेट करना है, जब विड्रॉल्स आए तो आपने देनी है. ठीक है,
हाँ.
तो बुप्रेनॉर्फिन इज अ पार्शियल एगोनिस्ट, वो भी विड्रॉल्स करवा सकती है. नलोक्सोन तो अगर हम एकदम से देंगे, वो तो एंटागोनिस्ट है, वो भी विड्रॉल्स करा सकती है. तो जब हम उन दोनों को इकट्ठे दे रहे हैं तो पोटेंशिएट नहीं हो जाएगा.
बुप्रेनॉर्फिन विड्रॉल्स नहीं करवाती. ये 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 तुमने कहाँ देखा?
सर
बुप्रेनॉर्फिन
ये
विड्रॉल्स नहीं कराती.
ये
हाँ.
आपने आपकी ही स्लाइड्स में था कि हमने पहले विड्रॉल्स का वेट करना है, और उसकी रीजन नीचे ये लिखी हुई थी कि इसलिए वेट करना है क्योंकि अगर इमीडिएटली दे देंगे तो वो इटसेल्फ, इस स्लाइड में वेट फॉर, ये देखें, वेट फॉर मॉडरेट विड्रॉल सिम्टम्स, और उसके नीचे एक्सप्लेनेशन में है कि अगर हम इमीडिएटली दे देंगे तो वो विड्रॉल्स करवा सकती है क्योंकि वो पार्शियल एगोनिस्ट है. तो इसलिए हमने पहले विड्रॉल्स का वेट करना है, फिर देनी है.
सो अगर इस सिचुएशन में ये आप जो पार्शियल एगोनिस्ट की बात कर रहे हैं और जो आप ये स्लाइड को फोकस कर रहे हैं, precipitated withdrawals can be caused by buprenorphine displacing a full opioid agonist. इसलिए
एग्जैक्टली.
कर रहे हैं ना. और
जी जी.
नलोक्सोन तो वैसे ही विड्रॉल्स कराती है क्योंकि वो एंटागनिस्ट है. ठीक
यस.
है. अब सवाल ये है कि आप 12 से 24 घंटे की बात हो रही है
हम्म.
विड्रॉल्स के लिए,
ठीक है.
और फिर आप बुप्रेनॉर्फिन दे रहे हैं ताकि वो पार्शियल एगोनिस्ट जाके रिसेप्टर को ऑक्यूपाई कर ले, और नैलोक्सोन भी उस वक्त दे रहे हैं क्योंकि 12 से 24 घंटे गुजर चुके हैं, विड्रॉल्स रिड्यूस हो चुके हैं. अब आप विड्रॉल्स इंड्यूस नहीं कर रहे.
ठीक है. ठीक
तो
है, आप समझ आ गई.
अगर हम फौरन नैलोक्सोन देंगे विड्रॉल्स आ जाएंगे, बुप्रेनॉर्फिन फौरन देंगे विड्रॉल्स एग्रेवेट हो जाएंगे. एग्रीड, इसमें कोई डिसएग्रीमेंट नहीं है. लेकिन अगर हम
एग्जैक्टली.
कुछ वक्त इंतजार करते हैं और विड्रॉल्स इनिशिएट हो जाते हैं, और काउस का स्कोर जो है वो 24 से 48 घंटे के बाद काउस का स्कोर हम चेक करते हैं, और काउस का स्कोर से सपोजली 13 पे आ गया है, या 13 से कम हो गया, या 13 के बराबर है, या 13 से थोड़ा सा ज्यादा है, अब विड्रॉल्स उसको आ गए हैं, तो हम मैक्रो डोज देंगे. अगर काउस का स्कोर 13 से ज्यादा है लेकिन 12 घंटे से ज्यादा गुजर चुके हैं और 18 घंटे इंटरमीडिएट एक्टिंग ओपियोइड के गुजर चुके हैं, तो हम स्टैंडर्ड डोज देंगे. और काउस का स्कोर कम है, अगेन आप टाइम ऑफ एडमिनिस्ट्रेशन को दोनों के साइनर्जिस्टिक इफेक्ट से मिक्स ना करें, क्योंकि दिया जा वो दैट टाइम इज इंपॉर्टेंट. इस स्लाइड में जो ये चीज मेंशन की गई है कि वो प्रेसिपिटेट कर देगी, तो एक्यूट स्टेट में तो आप नहीं देंगे. आप तो एक्यूट स्टेट में नैलोक्सोन भी नहीं देते. नैलोक्सोन आप उस सूरत में देते हैं एक्यूट स्टेट में जब आपको नजर आ रहा हो कि इस बंदे ने मर जाना है ओवरडोज से.
पिन पॉइंट प्यूपल्स ओवरडोज के टाइम पे हम देते हैं.
फिर आप नैलोक्सोन देते हैं ना, ताकि वो यार वो निकल जाए. इसको विड्रॉल्स जो आएंगे हम देख लेंगे, लेकिन कोमा में तो नहीं जाएगा ना. सो वो लाइफ सेविंग सिचुएशन है जब आप विड्रॉल्स इंड्यूस कर रहे हैं नैलोक्सोन देके. लेकिन आप उसको अगर मेंटेनेंस में लेके आ रहे हैं कि विड्रॉल्स कम होने शुरू हो गए हैं, अब लो डोज से स्टार्ट करके ग्रेजुअली टाइट्रेट करें कि विड्रॉल्स भी बेयर मिनिमम हो जाएं, कॉम्प्लिकेट भी ना हो, और डोज आहिस्ता आहिस्ता बढ़ जाए.
ठीक है सर, अब मुझे समझ आ गया कि हमने बेसिकली दिया ही तब है जब विड्रॉल्स आ गए. ओके.
हाँ, अगर हमने एक्यूट स्टेट में दे दिया तो मतलब एक्यूट स्टेट में वो अभी वो इंटॉक्सिकेटेड नहीं है, और फिर दे दिया तो फिर विड्रॉल्स आएंगे ही आएंगे. तो हम थोड़ा इंतजार करेंगे, विड्रॉल्स आ जाएंगे, फिर दवाई देंगे ताकि आहिस्ता आहिस्ता ये उसको ओरिजिनल कंपाउंड्स को रिप्लेस कर दे और बैलेंस कर दे.
ठीक है सर, थैंक यू.
क्लियर हो गया ना? टाइम ड्यूरेशन इज इंपॉर्टेंट in both the situation. QTC interval prolongation is also a problem with methadone. Drug interactions may happen. Yes, drug interactions methadone के काफी हैं, और ये बात पहले भी हो चुकी है कि उसके ड्रग इंटरेक्शंस होते हैं और हमें लिवर को और किडनीज को और बाकी सिस्टम्स को मॉनिटर करना है. मैथडॉन केयरफुली दी जाती है, सिस्टमैटिकली दी जाती है और बड़े प्रोसेस से उस पर चलना पड़ता है. ठीक है, गॉट इट? एनी अदर क्वेश्चन?
अच्छा
हाँ
सर, एक क्वेश्चन इस तरह से था कि अभी हम रिसेंटली जो अटेंड करने गए थे, ये ओरल ओपियोइड एगोनिस्ट क्लिनिक्स खुल रहे हैं और मेयो हॉस्पिटल में पहला वो लोग लॉन्च करने लगे थे, तो वो सर उनका मेन फोकस इस पे था कि ये इटसेल्फ भी सब्सटेंस ऑफ मिसयूज हो सकती है, यानी इनका इटसेल्फ भी अब्यूज पोटेंशियल है. तो उसको आप किस तरह से देखते हैं फिर, जब हम इन चीजों को मार्केट में अगर ले आएंगे और कॉमन कर देंगे तो?
सो मैथडॉन डेफिनेटली और बुप्रेनॉर्फिन दोनों एडिक्टिव हैं बिकॉज दोनों ओपियोइड एगनिस्ट हैं, राइट? लेकिन मैथडॉन में भी ये है कि यूफोरिया नहीं है, बाकी सारी प्रॉपर्टीज उसी तरह की हैं जैसी ओपियोइड्स की होती हैं. सारी प्रॉपर्टीज वही हैं जो ओपियोइड्स की होती हैं एक्सेप्ट फॉर यूफोरिया. सो हम हार्म रिडक्शन की बात कर रहे हैं. लेकिन अगर ये मार्केट में ओपनली आ जाती, जैसे कि अगेन यूएस और बाकी जगहों पे ये जो स्पेशलाइज्ड क्लिनिक्स पे मैथडॉन प्रिस्क्राइब हो रही है, तो ऑब्वियसली इसका पोटेंशियल ये होगा कि यूफोरिया मिले ना मिले, लोग जो हैं वो 6-6, 8-8 गोलियां खा के ओपियोइड एगनिस्ट इफेक्ट बाकी तो ले सकते हैं. सो यस, potential of abuse is there and potential of complication is there as well because it's a controlled drug in a way कि इसकी डोजेज अगर उसने ज्यादा ले ली तो उससे मरने के चांसेस भी बढ़ जाएंगे. सो फिर आप हार्म रिडक्शन तो नहीं कर रहे. हार्म रिडक्शन का मतलब ये कि सुपरविजन में, कंट्रोल्ड स्टेट में, खास डोजेज में फॉर अ लॉन्गर पीरियड ऑफ टाइम, ताकि आप एक्चुअल इफेक्ट्स ऑफ ओपियोइड्स को खत्म करके और जो उससे कॉम्प्लिकेशंस होती हैं लॉन्ग रन में उनको करेक्ट कर सकें. ऑल्दो in the beginning, when I started my presentation, I mentioned it again that we were giving opium tablets and we were trying to taper it off. And I still believe that the opiums and opioid derivatives are relatively less harmful than designer drugs. I have a firm conviction about it that these designer drugs, crystal meth, ecstasy, NMDA receptors, they are more dangerous than these drugs. Natural compounds like opium. और मैंने मिसाल आपको 100 साल के बुजुर्ग की सुना दी. Right? Anything else? So Manur, you don't have any question?
No, sir. Not now. Not.
Okay. I hope the newly married couple is happy and comfortable. Best of luck, right? And
शादी की ये तब्दीली भी है, सवाल खत्म हो गए.
वो expected है ना थोड़ा बहुत तो. So I'm not saying too much about it. I will talk about it some other time in a personal conversation, not on a public forum, right? शादी पोस्ट ग्रेजुएशन के दौरान यहाँ पे कुछ कामरान, मेरा ट्रेनी यहाँ पे मौजूद है, इसको पता है, आई वॉज वेरी मच अगेंस्ट अ मैरिज ड्यूरिंग द ट्रेनिंग. और उसकी मल्टीपल रीजंस हैं. उनमें से एक रीजन ये भी है, वो यूफोरिया और डिस्फोरिया ओपियम के बगैर भी हो जाता है.
सर कभी कभार वैसे भी मैं क्वेश्चंस नहीं करती है, आप लोग ऐसे लिंक कर रहे हैं.
क्यों कामरान? मेरी यही थी ना ख्वाहिश हमेशा के दौरान रेजिडेंसी आपने शादी नहीं करनी.
जी सर, मैं जब मैंने